So I'll be talking to you about management of pediatric keratoconus in children, and pediatric keratoconus should be diagnosed before adolescence. The management of ocular comorbidities has to be done like vernal catarrh, and there's accelerated progression, 88% as compared to adults. Significantly, it is more severe at diagnosis, 28% in stage 4 versus 7.8% in adults, and it affects the quality of life in children and adolescents. So there are many management challenges because of scarcity of functional complaints in the children, high accommodative power in children which compensates for distortions, and so the functional complaints, they come much later. The fact that there can be amblyopia, children are less compliant with the hard contact lens fitting, and corneal transplants in general carry a higher risk of graft rejection. So, given these facts, it is important to counsel the children for not to do frequent eye rubbing, and also one has to manage the ocular comorbidities. Of course, diagnosis we all are aware of is very much similar to like that in adults, but it is important to know that ophthalmoscopic signs are more frequent in children. Asymmetry of the keratoconus is again more significant in children, and cones are more likely to be centrally located in the pediatric patients. So CXL may be more beneficial for children. Now, this is the treatment algorithm for management of keratoconus, which we published in British Journal of Ophthalmology. And collagen cross-linking is the way to go for cases that are progressing because it increases the biomechanical resistance of the cornea. It should be done in cases where there is documented progression, but in case of children, I think we don't even need to wait for documentation of progression. Change in keratometry more than 1 diopter over 1 year, astigmatism more than 0.5 diopter over 1 year, and thinness pachymetry more than 20% over 1 year. Suffice it to say, in contraindications, that corneal thickness less than 350 micron should not be cross-linked, and so also the severe corneal scarring cases. There are currently 3 protocols which are used in children, and if we look at the various comparative studies as well as meta-analysis, both conventional and accelerated protocols are comparable, but it is the transepithelial cross-linking which gives suboptimal results. This is our publication on pediatric keratoconus, topographic, biomechanical, and aberrometric characteristics. And technique of accelerated collagen cross-linking is similar. We like to do this in children because it is faster, especially if the child can cooperate. And if the child cannot cooperate, then one has to use general anesthesia. So in these cases, epithelial debridement is done, followed by installation of isotonic riboflavin for 15 minutes, UVA exposure with riboflavin installation, which is done for 4 minutes, and then bandage contact lens is given. This is our study on 116 eyes with pediatric keratoconus, and as we can see, there are more males as compared to females, and more the age group between 10 to 16 years was the one which was most affected. Almost half of the cases were in stage 3 and stage 4, which means they were moderate to severe, and acute eye drops, it is important to note, was present in 8% of the patients, and healed eye drops was present in 19%. That means, again, they were very severe. Non-progressive keratoconus was seen only in 1/3 of the cases, and half of the cases had progressive keratoconus. So this is just to show what we did in these eyes. Almost half of the eyes we could cross-link, and the other half of the eyes either were okay with spectacle or contact lens correction, or we had to do DALK or penetrating keratoplasty, or even inject gas because they were so severe. So if you see the results after collagen cross-linking, the visual outcomes, they do become better, and this was significant. So does the topography, which is significant. Pachymetry does decrease, which is again expected, and which is significant. The aberrations do become better after collagen cross-linking. But there are problems with cross-linking in the form of sterile infiltrates, mild corneal haze, and infectious keratitis, which we saw in one eye. Progression we noted in 7 eyes out of 116, despite the fact that we had cross-linked them. And keratoplasty was required in 6 eyes, which means 6 to 7% of the cases or children may require keratoplasty. Acute eye drops, while we were following that, developed in 1 eye. So spectacle only cases also did well. These did not document progression, so they were not cross-linked in that study. Again, contact lens fitting, rose scale lenses was used, and there was significant improvement in the visual acuity. And the penetrating keratoplasty again showed significant improvement for severe cases, and so did DALK for these severe cases. This is just to show how intracameral C3F8 injection was done in one case which was present in this cohort. So cross-linking halted progression in 80% of the eyes and improved BCVA, UCVA, and total higher order aberrations at the end of 1 year. Just to show a pentacam of a case where keratoconus pre-cross-linking and post-cross-linking, which has stabilized at 6 months. And this is another case with 54.5 diopters of astigmatism, which progressed by 1.6 diopters of astigmatism, despite the fact that we had cross-linked the case. And this may happen because if they do not stop eye rubbing, or if they have vernal catarrh, because inflammation can also cause progression of keratoconus. We compared our cohort of VKC versus non-VKC keratoconus, and we found that there were steeper corneas with VKC, and there were more advanced presentations with VKC, which is expected. Coupled with that, there were more sterile infiltrates. So to conclude, keratoconus in children is more advanced, the progression rate is faster, frequent follow-up is required. Cross-linking at presentation should be done. Accelerated cross-linking is efficacious, and progression can occur despite cross-linking if they do not stop eye rubbing, or if they have acute episodes of vernal catarrh. Future insights are that the cross-linking protocols need to be developed for adolescent eyes. They may not be same as that for adults. They need to be standardized. The biomechanics, healing response, immunological aspects are different, which values we have for the adults, but not so much for the children. And we require lifetime results for them because we are dealing with them at a very young age. Of course, redos is a reality with children, but how it has to be done, what time and how many times can we do it, that remains a question which needs to be answered in future. So thank you very much for your kind attention.
This is excellent study because this is an extremely challenging situation. First is detection, and many of these patients, they are associated with vernal catarrh also. But
Yes.
I think whatever guidelines and grade 4 where you did keratoplasty, they were different, entirely different group where
Yes.
it was very, very advanced.
Yes, sir.
But you said 80% of the children where C3R was done. It was halted, or I think
Progression was stopped, yes, sir.
So they have to be followed for long
Yes,
period of
sir.
time.
They have to be followed up long for redos, and those with the keratoplasty, of course, have.
Yeah, surely. Thank you so much.
Thank